Uh, Good afternoon, good evening, if you're not from India, from Dr. Reddy's laboratories. I am Dr. Krishna Chaitanya. I work as the cluster head for medical affairs team here in Dr. Reddy's India. And today I'm privileged to welcome all the doctors, all the orthopedicians to this academic feast on a Sunday afternoon. And the reason being, we have a stellar list of speakers centered by an international speaker around us to speak on a very pertinent topic in this meeting. And without further ado, let's begin today's proceedings. And for the first outset, I would like to invite Dr. Sachin Tapasvi, sir, who would be moderating the entire program. And it's my privilege to introduce him. He has completed his MBBS and MS Orthopaedics from BJ Medical College, Pune, and then he's a Asia Pacific Fellow. And he's a consultant at Jahangir Hospital and Deenanath Mangeshkar Hospital and OSO hospitals in Pune. He has over 2 decades of experience, and he is one of the pioneer in creating a fellowship program in adult reconstruction surgery. And a lot of young doctors have benefited by doing this fellowship. He's currently the chairman of sports chapter of Asia Pacific. He's a president of India Arthroscopy Society, chief editor of Asian Journal of Orthoscopy, and he's also the chair of ISAKOS Foundation. And at this outset, I would like to introduce Dr. Tapasvi to take over this meeting and begin the proceedings.
Yeah, thank you, Dr. Krishna. I think it's a great pleasure to be here to discuss this very important topic, which is the role of visco supplementation in osteoarthritis. So essentially, the key reason why we are here discussing this very topic today is because there is a definite gap in the treatment of the arthritic knee. Along with me today, we have excellent orthopedic surgeons from India. My very close friend, Professor Dr. Arumugam, who is the director of the SRMC or the Sri Ramchandra Center in Chennai. He's also the director for the Center of Sports Sciences, one of India's or Asia's pioneer sports sciences center, something which we did lack for a very vast time. And he would be taking over from me as the president of the Indian Arthroscopy Society. So there's a lot of sharing which is going to happen, and I think we have the correct person to help us with for this today's meeting. We also have with us Dr. Amit Kapila from Fortis Hospital in Mohali. We're going to be having Dr. Aditya Kapoor, who is going to be joining us. Another very prominent surgeon from the Virinchi hospitals in Hyderabad. We have Professor Jha, a very senior practitioner from India, whose main interest has been rheumatology and foot and ankle, and he's serving a lot of national as well as international educational and academic bodies with his vast year of experience. We will also be having Dr. Gaurav Rathore, who is from Noida, who again comes in with a very rich experience. But I think the key highlight why we are here today is to hear our main keynote speaker, Dr. Jane Fitzpatrick. She is going to be speaking to us on what should we be looking at with respect to visco supplementation. Of course, Dr. Krishna is going to introduce her more properly than what I would, because I think her introduction is going to run in a couple of minutes, not just a few seconds. But essentially, I think setting the context for today's meeting is that osteoarthritis remains a big challenge to all of us who are predominantly joint surgeons, musculoskeletal doctors. We have most of our clinics, catering to these particular patients. And as we all are aware, not all require surgery. So I'm just going to take you back about a decade ago when there was this study which was conducted in India, which looked at the prevalence of osteoarthritis for the Indian population. And this study was undertaken by the McKinsey Group, and they took about 100,000 patients with knee pain from the age of 45 to 65, and about 25% of them that had some knee pain in the last 4 years. 50% of those had a disability which made them sort of skip work for a week. A third of them reported significant decrease in their activity levels, and a further 50% of them had disabling arthritis. So about 2% of the Indian population across a cross section had disabling osteoarthritis, and if you multiply 2% into India's population, that runs in crores or in millions. But as a surgeon, yes, you would be looking to help them, but as a medical practitioner, as a caregiver to the society, what happens to the remaining 98%? Because you cannot deny them treatment, and if you have to stay away from work for a week, or if you make me suffer with knee pain for at least 4 weeks in a year's time, I'm not going to be a happy person. So I think quality of life is now eminent. We are looking not just in terms of activity, but in terms of quality of life. My friend Professor Arumugam, if all of you are not aware, he is as young as me rather, and he is representing India for doing water sports. So he's basically a rower, and he does international rowing competitions. So if he gets knee pain, I mean, he's not going to like it. And so all of us here who are absolutely, engrossed in looking after our own physical needs, we have to look after our career, and which is where we have this treatment gap for this 90% of population that we need to sort out. What is also very important to understand is that, yes, physical therapy, medication, drugs, analgesics, anti-inflammatories play a role. Bracing sometimes works, sometimes does not work. You have to correct the right indication. But I think what we're really interested now in this huge segment of orthobiologics, which has a variety of treatment options. We are looking at treatment options in the form of viscosupplement injections. We're looking in terms of using triamcinolone preparations. We're looking at manipulated blood products like PRP or autologous conditioned serum. We're looking at combinations of these, and we still don't have the correct answer. What really has helped us and what has stood for the last 2-3 decades has been the role of viscosupplementation, which has been really very consistent. And I think it becomes completely befitting at this particular juncture here that as a clinical practitioner, I really want to understand, when should I be using viscosupplementation? Why should I be using viscosupplementation? And the most important question is that, do all viscosupplement injections behave in the same similar manner? So biosimilarity, I think, is a very critical and key concept that all of us really need to understand, because 2 cups of coffee don't taste the same. They are different, and that's why we need to really take a deep dive into this very important topic. And I think I would welcome all of you on this fantastic session here. The whole scheme for today is going to be the keynote talk, and then we're going to be having illustrative case examples where we will look at this as a day-to-day clinical outpatient based scenario, which is something that we face in our clinical practice. And then we'll be having the great intellectual brains of Dr. Jain and Dr. Arumugam, as well as Dr. Rathod, who are going to help us understand the approach that we should have, which is a very practical based approach. And I think I'm really excited to being on this session for the next couple of hours, and I welcome all of you here. So I'm going to turn it over to Dr. Krishna now to properly introduce Dr. Jain, because I think it's really important that we are waiting to understand more about our keynote speaker, and then we'll be very eagerly waiting to listen to her presentation. So over to you, Krishna, to introduce our keynote speaker for today.
Yeah, thank you, Dr. Tapasvi, sir, for setting out the context for today's meeting, and then giving out the expectation from what can each doctor can look forward to this meeting. So I think before I introduce Dr. Jain, I'm quickly going to share the agenda for today's meeting. I hope my slide is visible. So the topic with which Dr. Jain Fitzpatrick was going to deliberate today is role of viscosupplementation therapy with emphasis on NASH-A technology. And there are 3 interesting cases with which the Indian senior orthopedic clinicians have come up today to have a discussion around this topic, followed by the Q&A session. and the conclusion by Dr. Sachin Tapasvi. And I think without further ado, I would introduce Dr. Jane Fitzpatrick. She's been a sports medicine specialist, and she has obtained her medical degree at the University of Melbourne, and she has done a PhD on biological treatment of tendinopathy from the University of Western Australia. And Dr. Fitzpatrick has over 35 years of experience in being a specialist in sports medicine practice. She's been working with elite teams and other organizations to manage the cases which come across. And as you can see, she has created a sports registrar and also ortho fellows in her department where she is practicing sports medicine. She's currently running 9 clinical trials, and each of it is one of its kind, and then would give us new ways into understanding management of osteoarthritis with visco supplementation. In the clinical setting, she has performed more than 10,000 injections in different joints, including shoulder, hip, knee, ankle, elbow, and small joints. And I now welcome Dr. Jane Fitzpatrick to take over the presentation. Dr. Jane, over to you.
Thank you so much. I'm just going to share my slides for you. Thank you for that very warm welcome. It's a great honour for me to talk to all of you, and I'm looking forward to the discussions with our panel. It's a terrific panel that you put together, and I'm really actually very interested to see the cases and super interested to have a discussion. So let me just kick this off with a little bit of thinking around visco supplementation generally. And I think for all of us, we just heard before the statistics around the prevalence of osteoarthritis in India, and I think that might be a good place to actually start. I won't go through too much of the day in my life. I just wanted to let you know that I have enjoyed my work in sports medicine for many, many years and worked with lots of different sorts of sports teams. And if I'm correct in what I heard before, one of our other panel members is a rower, and actually so am I. So we have some more things in common than we realised at the start. And one of the things that I really wanted to highlight just as we begin is just what do we all do clinically. And we wrote this paper last year in the British Journal looking at what sports physicians do. Interestingly, this could equally be orthopaedic surgeons without the surgical component, and potentially rheumatology as well. And most people will reflect and think that what we are seeing is elite level athletes, but in fact 90% of the patients that we all see are not elite athletes, but come from the normal population across all age groups, from the very young to the very old. And the important part, I think, is that they present to us with a complex range of musculoskeletal problems, and they do require rather extensive multidisciplinary care. So on the strength of that, let's actually dive into this a little bit further. As you just heard, osteoarthritis is extraordinarily prevalent, and interestingly, I read a paper today that indicated that the rate of increase of osteoarthritis is greater than we could have predicted based on age, or BMI, or many other factors. So it's a very complex disease. Age, sex, and obesity are actually quite important predictors of symptomatic knee osteoarthritis. But what we're finding now is that many of our patients are coming to us, and they appear to be quite a lot younger than you might have expected 20 years ago. I asked Stephen Graves if he could pull these figures for us from the National Joint Replacement Registry, and it tells a very interesting story that the rate of primary, partial and total surgeries for the knee has remained fairly consistent across time. But when we pull those figures for patients under the age of 55, you can see that there's been an increasing trend in this particular age group towards knee replacement surgery. And that probably reflects why it is that we're all seeing a younger cohort of populations in our clinical practice. I'm not going to spend too much time on the pathophysiology of osteoarthritis, except to say that I think that my view of it is changing, and we are much more interested now in the molecular explanation for osteoarthritis than we have been with what we might call the wear and tear philosophy. And so cartilage degeneration is now understood to occur due to imbalance, really a relationship between the degradation caused by pro-inflammatory cytokines and so on, and the inability of the joint to then synthesize further cartilage or protect the joint from damage. Other factors, as we heard before, play significant role in the development of osteoarthritis, but they're not the focus of our challenge today. If we look at diagnosis, the key point that I wanted to raise realistically is just to draw your attention that when we are talking about the role of visco supplementation, one of the things that we should be wary of is looking for joint swelling, particularly where there's involvement of other joints that might be an indication of an inflammatory arthropathy, as these are patients who don't do quite as well with our visco supplementation. So I think from the componentry of physical exam, that would be my key take-home message to consider. We know that x-rays are our gold standard, and I really just wanted to draw your attention to, we report many things in studies, but particularly rate them with respect to Kellgren-Lawrence scaling of the degree of osteoarthritis progression. So just so that you're aware that probably that's the common term that we might use today. In the whole scheme of things, of course, there are a lot of treatments for knee osteoarthritis, and what you're going to see me focus on today is really one component of that, but it's important that we don't forget the totality of all of the other treatment options that are available to us. I just want to reflect for a very brief moment on corticosteroids, because when I started in medical practice, they were perhaps the gold standard of care and maybe the only standard of care that we had access to at that time. And they do work to provide quite good short-term pain relief. The reapplication of corticosteroids, though, doesn't give as good a long-term result once it's repeated consistently over time. And we know that there is some concern about the potential for greater cartilage loss with reapplication of corticosteroids. So if you reflect on the fact that we're seeing younger patients, this is something that we may not want to actually see too often. I'm just going to look now at where then would we put our HAs in? Where would we put our visco supplementations in? Surgery is still the gold standard for severe osteoarthritis and for those in the community with progressive disease. And potentially those things that you see in the bottom of my pyramid here are still the things that we often will start with. But then almost alongside of those, that's where the role of visco supplementation comes in with that mild to moderate osteoarthritis, although there is still some role for HAs in the more severe form of the disease. The things that I like to think about for my patients are we dealing with a category of medication that's safe? And almost 50 years of treatment with hyaluronic acids has not really brought up any significant safety issues in osteoarthritis. So that's quite nice to be reflective of. And then the second question is, do they actually work? And if we look here and see this nice meta-analysis that actually identifies the clinical effect size, shows us quite nicely that our HAs are actually of a similar or perhaps greater effect size than corticosteroid. But that's good, because if we know that corticosteroids work and we know that our effect size with intra-articular HAs is quite similar, it gives us two alternatives to consider in our patient population. Our introduction actually alluded to this, and this is something that I think about very, very frequently, is in fact, are all HAs the same? I will dive into this a little bit more deeply, but if we actually look and split our HAs and then look at the effect size, what we find is quite fascinating. So here on the right, what you see is minimal clinically important differences. In other words, if you sit within the pink zone here, then we regard those treatments as being relatively effective, or at least having an impact in osteoarthritis. And if we look at the intra-articular hyaluronic acids generally, what we find is that they sit in the middle. As soon as we split them into low molecular weight hyaluronic acids, we see the effect size there is approaching 0.2. And when we start to look at our high molecular weight hyaluronic acids, the effect size is much more significant at nearly 0.6. And so it is important to actually understand this concept, that this is one way to split our hyaluronic acids, and it does come with different benefits. The other thing to consider is that if this is true, do they actually delay the time to total knee replacement? Because this is what my patients are actually interested in. And if you look at this graph here, what it demonstrates that the re-administration of 1, 2, 3, 4 or 5 courses of HA does delay knee replacement surgery very consistently across time. So something very nice for our patient population to reflect on. So let me just take a little bit deeper dive looking at HAs. Hyaluronic acids are large glycosaminoglycans made up of repeating disaccharide chains. None of us are that fascinated potentially by the chemistry, but we do need to think about them. I think this is the best way that I have come across to actually think about how to split the hyaluronic acids. We've talked about the fact that we could split them by molecular weight, so let's discuss that first. Normal healthy hyaluronic acid has a molecular weight of around about 5,000 kilodaltons. Of course, it varies a little bit, but roughly that will be our average. And there are very few HAs that have ever been produced that have been able to get to that level. These ones that you see here, Durolane, Synvisc, Synvisc 1, maybe Gel 1, but none of the others have come close to the molecular weight of normal hyaluronic acid. Interestingly, we can split hyaluronic acids into either being linear, non-cross-linked, or cross-linked or modified. And if we look at normal healthy HA, is a linear, non-cross-linked version. No one's ever been able to produce it in as well a situation as Mother Nature has already done for us. And this is why we turn to the cross-linked or modified hyaluronic acids to get both that longevity and the molecular weight that we require. So if we look at our HAs, they have very significant roles: chondroprotective, producing proteoglycans and glycosaminoglycan synthesis, anti-inflammatory and mechanical effects, and analgesic effects. I'm actually just slightly highlighting these because I think they're important, because some of these work with some molecular weights better than others. So the chondroprotective effects are one that really is quite demonstrably changed by molecular weight. And so there is a binding of the HA with the CD44 receptors, and this helps to protect the articular cartilage. I will point out that this is much stronger with high molecular weight HAs than it is with low molecular weight HAs. So whilst our low molecular weight HA may produce some analgesic benefits and other anti-inflammatory, they're not quite so good in the chondroprotective effect. And actually in human studies, what we see is that actually re-administration of hyaluronic acid does in fact protect the articular cartilage over the passage of time, and this has been well demonstrated. And it's also better with higher molecular weight than lower molecular weight. We have these biosynthetic effects of HA in the joint, which the ones that we inject then lead to endogenous production of further hyaluronic acid and the proteoglycans, which is all good. And they have an anti-inflammatory effect. I know this has been argued for many, many years, but fortunately we're now all in agreement on this one. And you'll note those growth factors there, TNF-alpha, which our rheumatology panel will be very familiar with, and the interleukins there. I will note for you that those are the same ones that we discussed when we're talking with PRP. So it's an interesting crossover between the effectiveness of the two treatments there. So this is just a nice slide demonstrating the anti-inflammatory effect of HAs, which is in fact quite significant. And if I think now about the specific technologies, I'm now going to actually think about, is there a difference with some of our HAs, and particularly when we start to look at the NASHA technology. So what we're going to focus on for a little while here is the hyaluronic acid that sits at the top right-hand corner here. So it has a high molecular weight and it's cross-linked or modified utilizing the NASHA technology. So what does that produce, and what are we talking about here? What it produces is a clear, transparent, viscous gel of highly purified, stabilised, non-animal-derived HA that's biosynthesized using bacterial fermentation, which arguably means that it's less likely to produce allergenic effects once injected into a human joint. The NASHA technology is fascinating when you dive into it deeply. It's used to cross-link the natural entangled hyaluronic acid chains to produce a viscous gel. The cross-linking is so effective that it doesn't need to be done at a great amount, so it's minimally cross-linked, and it produces these enormous beads of molecules of HA that have a very significant length of duration of action in the joint. And I think of that as being the Visco supplement, therefore, with the longest residence time, which we'll see in a moment. And it's actually degradation resistant, so it actually sits in the joint for an extensive period of time before being degraded to HA molecules. It's one of the only HAs that's been studied in humans, that the data is actually available and known. But we can confer from rabbit or animal studies, it still stands as the longest residence time of all HAs. Oops, not sure what that was, wasn't me. Now, if we look at the number of studies that have been done, there are a myriad of them, and I'm only going to have time to really run through a few of those for you. But I will try to give you at least an insight into some of them, and I'm most happy to share them with you later if you're interested. So we talked about the pain-relieving effects or the properties of Durolane, and in an animal model, what we actually see is quite fascinating. The longer residence time of the Durolane correlates with better pain mitigation than the next leading brand, and much more significant than low molecular weight HAs do. The same is inferred with increased ability in an animal model to weight bear, and the same inference against those lower molecular weight products. So very nice to see that actually has a genuine benefit. If we look at cartilage preservation, we've already alluded to that a little bit before, but I just wanted to identify for you that the impact in both an animal and human model shows us there's significant reduction in cartilage erosion and fibrosis generation and maintenance of articular cartilage on MRI. So let's look at the human trials. This is my favourite. Ross Layton, who's a great colleague and friend of mine from Canada, really did this multi-centre trial looking at 442 patients with osteoarthritis in the knee. 26-week follow-up in the first instance, and they were looking at responder rates as well as pain scales. And what we see from that is that at around about 26 weeks, what you find is there's a significant benefit of the Durolane compared to methylprednisolone, which is maybe what you would expect, but nice to actually see that it does have that improvement at that period of time. This study actually allowed patients at 26 weeks to have a crossover, so both the methylprednisolone patients and the Durolane patients received a second injection, both of which was Durolane. And what you see is that then gave significant benefits to both groups, but the Durolane plus Durolane gave a better benefit than the steroid plus Durolane did in its outcome measure. And the effect size favoured Durolane right out in every possible measure, from pain through to function and also stiffness. So very convincing. The one that's really key to my heart here is that there weren't significant adverse events, and of those that were there, they were really minimal: arthralgia, injection site pain, the sorts of things that can be monitored and managed over 24 to 48 hours, but nothing untoward. If we look at this one, which just compares the top 2 molecular weight HAs on the market at that point in time, still in fact is the same, we look to see whether there's any difference with a higher molecular weight. And what we find is there is a greater reduction in knee pain with the higher molecular weight Durolane than with Synvisc 1, which is the next nearest molecular weight, which is quite significant and really does actually give us a little bit of insight into what's happening with that molecular weight. Now, I've been asked for many, many years what happens with second or subsequent injections, and are they better, second or subsequent ones, and how long does an individual injection actually last, as opposed to the efficacy studies that we've just reviewed. So we undertook a long-term outcome measure study here looking at NASH technology in osteoarthritis, which was a 6-year study, and it involved 727 joints. The purpose was to determine the length of symptom relief following repeated HA injections, and it was measured by the number of days between injections, and in addition, we looked at patient satisfaction with the procedure, which I'll highlight a little bit more for you shortly. So this was done through the University of Melbourne, 623 consecutive patients and 727 joints. So clearly some patients had more than one joint engaged in the study, knee, hip, shoulder or ankle, and they were all performed by a single clinician between 2013 and 2019. The demographic data is really important because then you can see if this reflects the same practice that you have. So what we had was an average age of 57. We had a youngest age of 21 and an oldest age of 92. So actually crossing the spectrum of all patient ages. We had a male-female ratio with 47% males and the remainder females, which is consistent with the amount or the demographics of osteoarthritis in the population. What might surprise you is the number of hips we had, so 53% hip injections in the series as opposed to 44% knees, which is reflective of the fact that I work in a hip arthroscopy practice as well with hip surgeons. We had patients going through from Kelber and Lawrence grade 2 and 3, which is what you might anticipate. And I did allude to this before. We actually also had 25% of our patients with severe osteoarthritis who have Kelber and Lawrence grade 4 OA. So let's have a look and see what happened to these folk. When my research assistant came to me, it was a Thursday afternoon, and she told me about the results for this study. I looked at this and she said to me, Jane, the average duration of action of a single Durolane injection is 466 days in the first instance and over 400 following that. Something in the order of 14 months. And I said to her, Georgia, please go back and rerun this data. I am very surprised by this. We need to make sure that we haven't actually miscalculated something somewhere. I'm amazed that we would get this length of duration of action. So having checked that 3 times, we found that this was in fact the case. So very, very interesting when you do a reflective exercise like this clinically to discover just how long these injections actually last. And this is almost certainly related to the fact that the molecular weight is there and the degradation resistance accredited to that NASH technology confers a longer effect time in our patient population. And if you look here at the mean and the standard deviation, and then next to that what you'll see is the range. Whilst the average was 466 days, there were a very significant number of people who had out to 1,800 days, and this was consistent across subsequent injections as well. So this is actually the first clinical paper that identifies what do subsequent injections do and what is the longevity of a single injection, which I think your patients would be very delighted to hear. We wanted to know, though, what our patients actually thought and whether measuring their duration of action by the number of days was actually correct. So what we did was actually go and ask all of these patients how they went and what length of duration of action they recalled getting from their injection series. So more than a third of the patients responded, which is a significant number. 70% said they would recommend an HA for osteoarthritis. There were 2.7% soreness after the injection, which we can discuss, but it's quite low compared to many other HAs. And if you look at this, 65% responded to their first injection, and thereafter the response rate for subsequent injections was better. The interesting part about that is all of you being clinicians will have already figured this out, that patients who didn't respond to first injections were less likely to have second or subsequent, and what we have is the responders actually continue to respond. So I think that's actually kind of an important piece of data to reflect on. And this one really made me feel quite chuffed, I have to say, that when we asked the patients what their reported length of symptom relief was, lo and behold, we got an identical picture to what we had measured in days. And that 75% of the patients had more than 6 months duration of action, but interestingly, the majority had more than 12 to 18 months of duration of action from their single injection. So quite outstanding management of their osteoarthritic pain. I won't labour on this, but I do want to reflect on the fact that our practice site does look at a specific treatment algorithm that does include a psychosocial approach to pain management, attitudes and beliefs relating to patients' pain. We do individualise load management strategies, as some of our higher elite level athletes need to lower their loads and some of our less active folk may need to actually increase their loads. Physiotherapy and strengths-based exercises were encouraged for all, and actually 82% of our patient cohort took up one of those forms of options. We manage weight as aggressively as we possibly can, and dare I say that may be something that you may need to manage in India as well, as we have that in Australia. And HA injections were our first line of treatment option. So you can see that patients were receiving 3, 4, 5, 6, 7, 8 or more injections, and only if they didn't respond to HA were we offering them other orthobiologics at that point the study was done, and of course arthroplasty surgery. So that reflects the treatment algorithm that we use, and I think the change that we've seen in using that kind of algorithm is that we really no longer use significant numbers of opioid analgesia, and we rarely use intra-articular steroids, as our intra-articular HAs are working for such an extensive period of time, and also with subsequent injections. So I think that's just changed our treatment algorithm over time. So I'm coming towards my conclusion, but I think if we reflect on this, the Turolane and the Nasher technology reflects a single injection stabilised HA, which is used for the treatment of osteoarthritis. It was actually the first HA designed for single-use injection and remains probably that with the longest duration of action, largely related to that amazing Nasher technology. The safety has been well established, and I'm really comfortable with that, and our studies have backed up the same figures that we've seen over a long period of time. So if we look at the technology, it is long-lasting and safe. It does have a high biocompatibility score. It's a highly purified hyaluronic acid produced by bacterial fermentation. We know it's both safe and long-lasting in repeated administration and has been extensively used. So I'm going to thank you all for your attention and throw back to my moderator. Thank you so much.
Thank you, Jane. That was, I think, a tremendous talk. Very, 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 very informative, because I personally learnt a lot of things there. And Dr. Krishna, do you want to take questions on this, on her presentation now, or you want to, do them at the end after the case discussions?
Yes, Dr. Tapasvi. We can do it at the end if it's okay.
Okay, fine. Any burning? Do you have any questions that have come in through the online viewers? If so, we can.
We are gathering them right now, Dr. Tapasvi. There's a separate link for the audience to put in their questions. We're collecting them right now. Okay,
fine, perfect. All right. So I think, as per your suggestion, Jane, I have a couple of questions for you, but we'll go with the questions at the end, as has been suggested to us by Dr. Krishna on your presentation, because I think it's very pertinent that we discuss the issues about biosimilarity, since that seems to be one of the key reasons why a physician or a surgeon should select this particular therapy and judge the response.
Dr. Tapasvi, if Dr. Jha here.
Yes.
Yes, I just wanted to say, while it is very fresh, why don't you discuss it with some questions now?
I'm more than happy, I think.
Yes, I think that will be very opportune.
Okay, fine. Take it. So I think any questions from all our panelists here? Professor Arumugam, you have any questions on this topic?
A very excellent talk by Dr. Fitzpatrick. And also she clearly mentioned the algorithm of treatment of ONE, pretty much what I follow in my center. Only question is, Dr. Jane Fitzpatrick, how about giving the hyaluronic acid and leukocyte poor PRP and same sitting, given some recent studies have shown hyaluronic acid is good in an earlier outcome up to 6 months or so. The PRP takes care of longer duration of pain relief. Is there a role of combining hyaluronic acid and the PRP in same sitting? Because in our setup in India, the patient don't like to be injected more often. So if you can do the same sitting, I wonder what will be your opinion on that.
That's a wonderful question. And for those of you who don't know, I actually did my PhD in PRP technology. So close to my heart, this question. So there's a number of ways that I could look at answering that. And I think the fact that I have a number of ways to answer it probably means that we don't yet actually truly know the answer from a research perspective particularly well. However, if I look and see what happens in clinical practice, if we look at just using an HA, then I can reflect on this and say that 75% of patients will get more than 14 months of duration of action or thereabouts from a single injection of Durolane at that standard cost. That's actually a really long time. And in my hands, the patients will then ask me if I want to add a PRP to that. One, we have limited science. It is evolving and it may well become something that we wish to use down the track. But that will potentially increase the cost to the patient. It might even double the cost to the patient. And so my very savvy patients look at me and say, okay, Jane, do I then get double the length of time? Do I get double the 14 months if you put the PRP in? And I think the answer is no. And so at this stage, it's hard for me to justify putting them both together when we get such an enormously beneficial length of time from HAs. So in my clinical practice at the moment, what I've been doing is to use the Durolane repeatedly for as long as we get genuine clinical benefit, and then swap to PRP or another orthobiologic, and bear in mind that I'm often doing research studies that allow me to access all sorts of other growth factor technologies that we would use in our non-responders to HA or in patients who have subsequently not responded. So I haven't burnt all my bridges. However, if I look at the research and I think what is the current research, there's one rather nice systematic review. I didn't put it in today's talk, but we might do next time. And what they have identified is a trend that would indicate that if you were using HA, that a high molecular weight HA is better than a low molecular weight HA. So that's the first thing. Yeah. And if you're using a PRP, that a leukocyte-rich PRP is better than a leukocyte-poor PRP. And if you use a combination, very limited studies to actually generate this data from, but it does appear that combining the high molecular weight HA with a leukocyte-rich PRP might give you the best advantage. So I suppose at the moment what I would say, if you are going to combine it, then that would be what the literature was suggesting that we would do. I'm sorry to take so long, but that's the way I view things. Does anyone else on the panel have a different perspective? Because I think sometimes that's interesting too.
Yeah. Yes, Dr. Jha.
No, I just wanted to say one thing. If you're, have you ever gone for mixing methylprednisolone with your hyaluronic acid? Or as you have shown, you want to give methylprednisolone earlier and then in later stages you have switched over to hyaluronic acid?
Yes, that's actually another good question, actually. And I think we've all used both methylprednisolone and HAs. I think that would be very, very standard in most clinical practices worldwide. My response to that is that I tend to use a steroid, be that methylprednisolone or other, in the first instance only where I have genuinely identified that we have a patient with inflammation related to osteoarthritis. And so potentially for those of you who have registrars and fellows here in the audience, I would be just mindful of the fact that sometimes these patients that look like they need a corticosteroid have an inflammatory arthropathy. And the one that my fellows and registrars frequently miss is psoriatic arthropathy, palindromic rheumatoid, the seronegative arthropathies. So I would just raise that as a flag, and I know that obviously our rheumatology colleagues will never miss these, but some of the more less physician-orientated might well do. So that's the first flag. The second thing is that if I'm using it, I try to use it once because I think that once we get the patients under control and their osteoarthritis is the pain is less, and they come back for their subsequent injections, they probably don't need a second or subsequent corticosteroid in my hands. But as you have identified, I probably would use one in the early phase in some situations, and there you could make a case for mixing them in that situation. There's one study, a very nice little study, however, that demonstrates that corticosteroids actually denature HAs, and they do it more particularly with low molecular weight HA. So I will caution you as practitioners that if you are going to mix them, which is not recommended by most providers of HA, that you do use a high molecular weight, more gel form, so that there will be less denaturing of your HA product. So that would be my response to that. But yes, it's the short answer.
Right. I'm happy we have talked about seronegative arthropathies also.
Yes. Ma'am, there's one molecule new coming up, triamcinolone hexa. Instead of giving methylprednisolone, can we use what you say about this? Because the studies says it remains for a longer period in a synovial fluid as compared to the methylprednisolone.
Yeah, so the longer-acting corticosteroids are interesting, actually. There is quite a few of them coming out, and there are a number of studies that I've seen at Ortho and other areas recently. So I guess the question about that for me is, why am I using a steroid and why am I looking for a longer duration of action? And the short answer is, for me, I will not be inclined to want to use them in osteoarthritis, because what I'm looking for are chondroprotective benefits that we get with the hyaluronic acids, particularly with the higher molecular weight HAs, in conjunction with some anti-inflammatory effect. And when we use a corticosteroid of any format, we get those wonderful, powerful anti-inflammatory benefits, and we don't then get any of the benefits in the CD44 receptors or in the articular cartilage. And we also don't get the endogenous production of hyaluronic acid. So I think, for me, I look at it and think, for my patient with osteoarthritis, if I'm trying to give them the very best outcome, then my focus is normally towards things that are going to be chondroprotective in addition to those that are anti-inflammatory. But I do understand the value, obviously, of a long-acting steroid, particularly in our inflammatory arthropathies. And I think that's probably, I'd be interested, Dr. Hua, whether you feel that there might be a very nice benefit in those some of those subgroup populations.
Thank you.
Yeah, Jane, there's another question that's come up, and I think it's a valid question that gets asked and referred to quite often. Is that I did your last couple of slides where you did present, you had a variety of joints that you had injected. So the question is that is IAHA, does it show the same efficacy as it does, say, in the hip or the shoulder or the wrist or the ankle, as it does, with the data that we have for the knee joint?
Actually, that's a really wonderful question. We actually looked at our data where we had roughly half hips and knees. If you look at the statistics, you'll see that. And what we found was that there was no difference, particularly. There was no statistical difference in the outcomes of the hips versus the knees. In fact, the hips did just as well as the knees did. So that's one that we can confer immediately, because that comes from the same population study, and it's measured over the same time frame, in the same kind of demographics of patient population. So I think we can pretty happily say that that's likely for hip and knee. With respect to the shoulder, actually, we were using something else for our shoulders at the time. We hadn't actually changed across, so there are fewer shoulders, and we were using Durolane SJ in our ankles, so a little bit different to correlate. But from a clinical perspective, there are research papers that infer that the changes are true in all synovial joints, and whether this is better or not in a different joint is harder to confer. Particularly difficult is the shoulder, and so for those orthopaedic surgeons in the room here will know that shoulder osteoarthritis presents very frequently in a later stage than knee osteoarthritis. And so what we're comparing is grade 4 shoulder OA with grade 2 and 3 knee, and it's a much harder thing to compare. So it's actually a little bit more difficult. But my clinical experience is that shoulders have worked very well, and the research studies would seem to infer that too. But just bear in mind that for joints outside the knee and hip, there are many less studies. So.
Yeah, I suppose you would be doing all your injections as targeted injections and image-guided injections?
I do, yes. I actually introduced ultrasound-guided injections in our clinic in Australia, and we do train all of our fellows and registrars in ultrasound guidance. Yeah. We're actually, just for your audience, might be nice to know, we just produced a video looking at both injection techniques in the knee and the systematic review evidence of which injection portals you should use and whether you should do that ultrasound guided. So that will shortly be available on the Bioventus Academy website. So we've been through all of those areas that people are fascinated to know the intricacies of, and it'll shortly be available.
Yeah, I think that's a very important point, because I do feel that, in my practice, all my injections are targeted injections. They're all image-guided injections. We have stopped giving blind injections now, because I feel that, if I'm the patient, I need to understand, and I need to have that right that the drug that is being used has to go in the right location. And I'm going to request Dr. Krishna and the team from Dr.Reddy's is that once your video is out, I think it would be very nice of them to share that link from the Bioventus Academy to all the people who are interested, all the doctors who are interested, because it makes a lot of difference when you start doing image-guided injections. So,
Sachin, quick question. Even for a knee, you give ultrasound-guided injection? My shoulder, other joints I do, but not for the knee. What about you?
So if there's an effusion in the knee, I think, I aspirate that effusion, that becomes something like a confirmatory test that I'm in the right place. But if the knee is dry, then I will always do it ultrasound guided.
Okay.
And it makes life...
Dr. Tapasvi, I've got a question for you.
Yeah.
Dr. Jain,
Yes.
Every now and then, if there's an MRI conducted, you also see some bone edema. What is your experience with patients who've got bone edema and arthritis when you inject them? Do you find that there is the Durolin is not so effective in that setting?
Actually, that's a fabulous question, and I'll give you a clinical answer to it. There is some research in this area, but not as much as we would like, despite the fact that there is quite a significant prevalence of bone edema. So that's something I look for in a patient who has more pain than I expect for the level or grade of arthritis that they have on their X-ray, or who's had a very sudden increase in pain that doesn't seem to be reflective of the level of arthritis that they have. And so for those, they're the ones that we often find have that bone marrow edema or insufficiency fracture in the subchondral bone. And I think with those patients, we can play around with the idea. But what I have found is probably like you, that if you only inject a hyaluronic acid, that you're not dealing with the bone part as well as we would like from that patient perspective. And the other alternatives, of course, are to concurrently administer something to try to help with that. So we've actually done a small trial of patients with bisphosphonates. So we use Prolia or a cluster to try to manage the pain from their bone marrow edema or their insufficiency fracture. And that's been quite good. And if you look at the literature, you'll also see that there are all sorts of new techniques which are being postulated to manage that subchondral bone space. In fact, Bioventus is coming out with a new product. It's not yet determined when you will have this in India, but it's called CartiHeal. And what CartiHeal does is an implant which you put into the subchondral bone that grows new articular cartilage over the top. And what my personal reflection of this, having looked very carefully at the literature, is that probably what this is reflective of is many of our osteoarthritis patients' problems are driven by the subchondral bone. And so we do need to actually pay attention to what's happening there. So great question.
So I think I would agree with you, Jane, on this, is that subchondral bone is, it's like the base on which the cartilage thrives or lives. And also, I think, Dr. Aditya, one thing that is that we need to find out, why does the bone marrow edema suddenly occur? Many a times it would be as a result of a torn meniscus. They have a radial tear of the meniscus. Suddenly the hoop stresses go off, and then there's bone on bone impact which causes it, and we need to look at the mechanical reason as well. So I think great points that have got discussed.
Can I have one question more?
Yes, please.
Right. Dr. Jain, there are a lot of talks about phenotyping in osteoarthritis. Do you think phenotyping has an effect in ultimate management of osteoarthritis?
I think we'd all like to think that the answer was yes, and probably the answer is yes, because what we know is that some patient characteristics confer an advantage for the use of HA and some don't. So, for example, the more inflammatory the patient's symptoms are, the less likely they are to respond to hyaluronic acid. So that's at least one point that we can probably all agree upon. But even despite that, when you use your HA in a native population, as you saw on my slide, statistically, there's probably around 20% of non-responders to HA that we see. And so I would, like you, love to be able to weed those out or to understand who they are, so that we can better focus the treatment for them into something that works. So I would genuinely love to understand that better, but I don't feel that we have quite got there yet. I mean, watching all of those studies, looking very closely to see if we can shed some light on those things. And I think it will be the future for us to really tailor-make the patient's treatment particular to them, which would be so wonderful.
Do these failed cases belong to very early enthusiastic use of HA when the disease pathology has still not stabilized?
No, actually, the non-responders fall across everything. They fall across age, gender, KL stage, joints types, and so forth. So, their polyarthritis and bilateral arthritis are also two that you could perhaps highlight and say that they're less likely to do so well. So polyarthritis, because there's an inference that it may actually be related to some form of inflammatory arthropathy ultimately. And I guess, on both sides, rather than unilaterals always do better than bilaterals historically through clinical trials. So we have some glimpses, but I don't think we have the full picture.
Right.
Yeah. Perfect. So I think if there are no further questions, we'll move on to the first case presentation. We'll invite Dr. Amit Kapila, who is from the Fortis Hospital in Mohali, which is near Chandigarh, to come with his first case. And the panelists for your case, Dr. Amit, will be Dr. Jain, Dr. Gaurav Rathod, and Dr. Arumugam. Over to you, Amit.
Yes. Good afternoon. I'm audible, I suppose. Yes. Thank you, Dr. Reddy, for giving me this platform to share my case. Fine. So I present a case of 48 years male doctor patient from the Fortis Hospital. He's a cardiologist. He's hypertensive with a BMI of 29.5 kg per meter. He's regularly exercising, workouts, gymming, and treadmill. He presented to me in August 2018 with pain in right knee. No history suggestive of any injury or fall. Clinical examination was within normal limits, no swelling. So he was managed on NSAIDs for 7 to 10 days. Doctor went back home happily. Patient was relatively symptom-free for 6 to 7 months, but in Jan 2019, pain and stiffness increased. So he came back to me again. So he said, now left knee also is involved, and said probably I will be more weight bearing on the left side. So I did some investigations, So there were some reduced vitamins and vitamin D3 levels and vitamin B12 levels. Again, so I initiated some specific vitamin treatment and anti-inflammatories, and I started on nutraceuticals. Patient did have mild relief in symptoms. So this was the X-rays on that time, June 19. So you can clearly see there's a needle joint space reduction in both the knees, right and left knees. So after 3-4 months, recurrence again happens and worsening of the pain after few months. So he came again back me in October 19. So I conducted an MRI of the patient. So this was the left MRI, so which is suggestive of there's some grade 1 tear posterior horn of medial meniscus with obviously on X-rays also and in MRI mild to moderate secondary OA changes. And there is some medial articular patellofasciate articular cartilage losses there. This is on the left side. So again, so MRI of the right knee also conducted. Again, there was mild to moderate secondary OA changes with the loss of articular cartilage over medial patellofasciate. There was no, a medial meniscus injury here. So in November 2020, I counseled the doctor and we gave first dose of injection Durolane. And the patient responded very well in relief of symptoms. So obviously I did, I have not did ultrasound guidance, but with the clinical experience from the lateral side, I applied it. So in November 2020, we gave the first dose of Durolane, and then he became symptom-free with no painkillers and everything. He's doing his duties. And in June 20, he came back to me with this new X-rays. So I counseled him and I gave the second dose of injection Durolane. And still he is happy with symptom-free. This is a clinical video of the doctor. You can see the gait of the doctor. A little bit of antalgic. So Visco supplementations in osteoarthritis, it is both for quantitative, as Dr. Jain said, for the qualitative deficiency. It admits visco-inductive properties in the knees, restores mechanical properties of the cartilage and synovial fluid, and it helps in the moderate anti-inflammatory effect also. So patients, it helps in not taking the painkillers to the patient. It reduces cytokine-induced enzyme production. It has some antioxidant action also and anabolizing the effect of the cartilage also. So take-home message is, it is easy to use, patients has good tolerance and enables economy of opioid analgesics and NSAIDs. But selection of the patient, right indication and cautions is to be implemented. Thank you, ma'am.
Thank you so much, Dr. Amit. I think your case is open for discussion. So, Dr. Arumugam, Dr. Gaurav, Dr. Jain, questions and comments, please.
A good case presentation for ideal patient selection for hyaluronic acid treatment. Only other question I would like to ask is, was there any scanogram done to see the alignment of the joints since the patient is not that quite young? Maybe.
Yes, no, sir. I didn't. Patient do have sometimes lumbago, low back pain is there because he's slightly obese also.
Okay.
I might make some comments. Thank you. It's a wonderful case, actually. In fact, it's a perfect case for, as you described, for the HA. And I think it does make the point that we haven't raised just yet, that malalignment is in fact one of the ones that we try to exclude from thinking about with our HA. So this patient's probably a little bit borderline in terms of having that joint space narrowing that is going to give him some malalignment. And so for me, I guess the additional thing that I would love to see him do is to try and entertain some weight loss. And I wonder actually whether he might have a metabolic syndrome just with a history of hypertension and that little bit of additional weight. So that might be something to work alongside him with, which would potentially mean that the next Durolane injection might last for longer, which is what my goal always is. But a wonderful case.
Thank you.
I think that was an excellent case. I think we see this in our practice very commonly. And for me, with the Durolane injection, I tell the patients that, this is the beginning of your treatment, and weight reduction for me, especially for a patient with that sort of body habitus, is quite important. As Dr. Jain said, this patient has most likely got metabolic syndrome. So every prescription of mine will mention a diet change, low carb diet, intermittent fasting. I tell that to all my patients. But I think that's a good case. And I think another thing what can be contemplated in patients like this is doing sort of a joint realignment surgery, an HTO. The other thing what I noticed on the MRI was extrusion of the menisci. I wonder if you combine some of these cases with a root repair, because that is another big thing which probably reduces. This sort of patient at the age of 60 would probably end up with a knee replacement. But, in late 40s, I think that's probably the best thing to do. Try and delay the surgery.
Yes. Wants to avoid the surgery also, and just he's pain-free. Now he's doing his activities and
yeah,
keeping fingers crossed.
Absolutely. I don't know, what the experience of other speakers is, but what I find to see is that, Durolane injection, the duration of action tends to reduce with time.
But you see, the first injection we did in November 20. The second time he came in June 22, after 1.5 years.
That's a very good effect.
The only issue is sometimes the Durolane, the effect, it slowly comes out. It doesn't give immediate, the effect.
That's correct.
So that part we need to counsel to the patients.
Yeah. And I think the use of steroid, I think there was a question earlier whether steroids should be combined. I think the only reason to combine steroid would be an earlier onset, because sometimes Durolane does take, in my opinion, it takes a few weeks to really manifest itself. I don't know what the experience of Dr. Jain has been on this. She probably has the maximum experience, but I find that Durolane does not act immediately. It has got a very long duration of action. I've used all sorts of hyaluronic acids, but I find that Durolane has probably got the longest action amongst all of them.
So I think I'll just do a quick follow-up question on this particular point, Gaurav, that you just mentioned. And the follow-up question that I have is that after administering, say, a Durolane injection, what is the outermost time limit beyond which you can say that, okay, this is not working for you? So how long would you wait for symptoms to resolve before you decide, or you make a statement when he comes for a follow-up? Okay,
so I think
this has not worked for you.
Yeah, I think that's a very pertinent question.
Yeah.
And I don't think there is a concrete timeline to that. I usually wait for about 4 weeks. I would initially give the patient a course of anti-inflammatory. Every time I do an injection, I would leave the patient on a very low dose piroxicam or something like that, or toricoxib, for about 4 to 5 days, because there are occasionally patients who come up with an increased pain after the injection. But for me, if it's not worked for 4 weeks, it's very unlikely to.
Okay. Aditya, what's your cutoff limit? Aditya, can you unmute yourself? Yeah. Aditya, can you unmute yourself? Okay, Aditya.
Yeah, sorry.
Yeah, Aditya, yeah. What's your cutoff limit?
I would wait for some time. I don't think Durolane works outright. And there have been some discussions that have happened where with people that, you need to wait for some time. I would wait, if I follow your question correctly, sorry, Is that how long Durolin works? Or you wait?
My question is that, not everybody will come back with a positive response, correct? So if someone is not, if someone does not have a positive response from your injection, what is the cutoff time period at the time of which you'll say that, unfortunately, this is not working well for you?
Right. So I think that is, again, a very multifactorial question. There are a lot of things that go into that. One is, at what stage of arthritis have you injected the patient? Because we know that the more advanced it gets, the lesser is the response that you're going to get. Was there an associated effusion with it? And then again, I find that Durolin doesn't work, or may not give you instant relief. I would wait for a couple of months before actually making that call. I usually wait between 6 and 8 weeks. We tell our patients outright that, you will need to wait for a period of time before it acts. It's not actually acting as a gel. It has to replace the factors in your knee. It's not a cushion. It has to have a chemical action inside your knee. Okay. So at the end of 2 months, if they don't respond, that is when I would consider a PRP injection, provided it's not severe arthritis.
Okay. Dr. Amit, what's your cutoff time period?
I take 6 weeks, sir.
6 weeks. Okay.
6
Dr.
weeks.
Arumuga?
About 6 to 8 weeks. I agree more with Dr. Kapoor that gives a reasonable time before switching to other alternative.
Okay. Dr. Jha, what's your cutoff time limit?
Yes, for me it is minimum 3 weeks and after, and maximum is 6 weeks.
6 weeks. What about you, Dr. Jain? What's your clinical preference? When do you say that, okay, this is probably not working well for you?
We say 6 weeks. Generally, what we find is that some patients, as you know, will get a good response within 1 or 2 weeks, and some are 3 or 4. And certainly by 5 or 6 weeks, you actually know pretty clearly whether they're going to be responding or not. And that obviously means that nothing else has happened in the meantime. They haven't slipped and fallen on it or whatever else. But assuming that they've had a standard course of time and tide, then I would agree. About 6 weeks. It seems we're all saying the same.
Yeah, perfect. Okay, thank you so much. We'll move on to the next presenter. It's a great privilege to invite Dr. Amit Kapila, who is the senior consultant at the Vinci Hospitals in Hyderabad. And Aditya, the screen is yours to share.
Just give me a minute, sir. I'm bringing it up.
Yep.
And right. Can you see something, sir?
Not yet.
Not yet.
No. Yeah. Parikshit, can you help him? Parikshit, Brijesh.
Yes.
Someone help him, please.
Sure.
There could be a share screen button, right?
Yeah. There's a green button down there. In case there are difficulties, I do have your presentation with me. I'll put it up. You will just ask me to.
I think you run it, Parikshit. In the interest of time, I think that will be better.
Yeah, I think so. For some reason,
I will do it right away. Yeah. Just give me a second.
Thank you.
Please run the Parikshit. Yeah.
Okay. Can we move on to the next slide? Yeah, if you don't mind.
Yeah, sure.
Okay, so I've got 3 cases and 3 different scenarios, and I won't take very long. First of all, good afternoon from overcast Hyderabad, and I thank Dr. Sachin, Dr. Fitzpatrick, and everybody for having me here. The first is a 54-year-old lady who I saw in 2016. And she had knee pain for about 6 months, slightly overweight lady with a BMI of about 32, no swelling, no clicking, no locking, and her VAS was about 4/10. She had difficulty with stairs, walking long distances, squatting, known comorbidities of diabetes, hypertension, mild varus, medial joint line tenderness, slight crepitus, and she scored about 35 on the Oxford knee score. Next one, please. And that was her radiograph. So what would you do next?
Yes, Gaurav? Okay, we don't have it. Aru, what's your take on this? What would be your line of treatment? Aru, you need to unmute, please.
I suppose the initial line of physical therapy, NSAID, all been finished, Dr. Kapoor? Or?
Yeah, so this is the initial X-ray. I have been using Durolane for about 12, 15 years now. So we actually saw that this is early arthritis. You would possibly say KL2. And next slide, please. So we gave her a short course of NSAIDs. I don't give it very long. We initiated nutraceuticals, knee braces. We all sent for physiotherapy. And we advised her Visco supplementation. Next, please. And at that point in time, there was this orange injection available, the box. Carry on, please. So we gave it to her about 3 months later and then saw her back. Her VAS went down to 2/10. Oxford knee score was about 39. However, she said that she was happy and doing well. Next slide, please. Right. Now this, go on, please, is the X-ray when we saw her when she returned in 2018. At this point, her VAS was 4/10 and she scored 34. So what would you do now?
Yes, Aru.
And so almost 2 years now since the initial X-ray, right? The previous
Yes, sir.
X-ray,
Yes, sir.
When was
The
that?
last X-ray, this X-ray was 2 years.
I would obviously repeat the X-ray.
Right. That is the previous
That's
one you
right.
saw was the fresh X-ray.
And she is 60 years only. So I would do for second dose of hyaluronic acid.
Right, sir. And that's what we did. Carry on, please. Right. And she actually asked for it. She was quite delighted with the first round, about 2 years, and it was repeated and it gave good effect. Please carry on. And then, COVID hit us and we saw her back in July 2022. She had been on nutraceuticals intermittently. In India, as you know, we don't require a prescription. Most people self-medicate. And she had been using my previous prescription. However, this time she had slightly more pain, reduced activities. Her VAS was 5/10 and her Oxford knee score this time was 24. Please carry on. And that's her X-ray this time, sir.
Yes, Aru.
Well, maybe I'll now she's 62, right?
That's right, sir.
62, and it is not a very advanced arthritic changes, still only mild to moderate. Maybe I'll counselor for another dose of hyaluronic acid, maybe this time combined with the PRP.
How soon would you combine with PRP?
Same sitting.
Same sitting, sir.
Yeah.
Okay. Dr. Sachin, your take?
I mean, I think this is probably time for me to try and do more imaging for her. So long leg films and an MR scan to find out what is the source of her pain. Yes, of course, she's osteoarthritic, but definitely is there something more that's going on with her meniscus, with her cartilage, is something that I need to see. And if she's coming back to me, in a span of 4 or 5 years, she's feeling good for 2 years and then again she has pain, I think this is the time probably I'll start speaking to her about some surgical intervention after having done a thorough, imaging evaluation for her.
What surgical intervention would you think of at this point?
I think I would need more. I think I would require more information. So I definitely want MR scan for her. I want to see what's happening to her menisci, to her cartilage. I need a long leg alignment film. I'd probably want a Rosenberg view as well. And depending on her clinical exam, I would then start counseling her either in terms of doing an offloading osteotomy, or if she's bone on bone, I would counsel her for a partial knee replacement, asking her what sort of lifestyle she wants to lead, and based on that, take it ahead. If I find that she's not bone on bone and she probably does not want any form of surgical treatment, then I would then go ahead and offer her a brace. I would offer her insoles and another injection, which is the way I would sort of try and tackle her at this stage of her disease.
Okay, next slide, please. So we actually offered her, she was already on braces, and she was using that intermittently. We had a detailed discussion with her. However, she was so adamant on Visco supplementation because of her previous experience that we offered her Visco supplementation. We've given it. It's been a couple of weeks now that she's had it. So far, she hasn't come back to me, but I'm waiting to see the response in the long term. Okay, can we carry on to the next? So this is something which I have been following, Dr. Fitzpatrick. Carry on, please. And please, again, just carry on. Yeah. And this is a lovely paper, which is something which I find that has helped me in my perspective with Indian patients. Carry on, please. Okay, so I'll very quickly discuss this case. There was a little bit of self-care, as you can see, because the patient himself is a critical care specialist. So this gentleman actually had a ACL reconstruction and partial medial meniscectomy 6 years previously, but this was done elsewhere. And at that point, it was done with an endobutton and a biocomposite screw. When he came to see me, he had some pain and swelling in the joint. He had been carrying on with long COVID duties. This was at the time of COVID. And his VAS was about 4/10. And clinically, there was a large effusion. There was no instability. And I couldn't find a positive McMurray's. So we asked him for some routine radiographs, which showed no reduction in the joint space. We asked him for a scanogram, but he didn't comply. Next one, please. And the MRI, which he carried out, was carried out of our hospital because, remember, he's a doctor, so he has his own access. And this is what the scan showed. There was an effusion. The grafts were intact. The tunnels were well placed. There was some amount of chondromalacia reported. Please carry on. And this is the film. This is what we saw. Please carry on. Yeah. And there was a slight, there was a vertical flap tear in the posterior horn of the medial meniscus as well, where they'd had the partial medial meniscectomy, but I couldn't elicit a McMurray's. Carry on, please. Okay. And his inflammatory markers were normal. We aspirated the knee. What would all of you have done? So I gave him a combination of a steroid because of the effusion, along with some Visco supplementation. Would you all have done anything differently here?
Let's start with Jane now. We'll go from the top below. So Jane, what's your take on this? What would you have done? What would your approach?
I think that probably you've covered all the bases. So there's no loose screw, there's no intra-articular pathology to speak of. But this is fairly consistent with patients who have ACL surgery. They often present, especially the younger ones, present with the effusion and chondromalacia before we see them develop terribly many changes on their x-rays. So I would agree with you. I think this is a great approach. And just use the intra-articular steroid after you drain the effusion and the Visco supplementation and see how things go. And then the other thing that I would just make sure to assess is just critical strength, because sometimes what I find is the patients after their ACL surgery haven't actually really regained their full strength, and it's really nice just to go back and assess their pivot weave strength and their ability to do things. But it sounds to me like you covered those bases well.
Yes.
Just a small question to everybody. I mean, how many of you would put an injection of hyaluronic acid in presence of a large effusion? Because I find it, I mean, that's not something which I usually do. I mean, if there's a large effusion, would you, if there's a lot of inflammation in the knee?
I would split the corticosteroid and the HA. So withdraw the effusion and use a corticosteroid injection, and then subsequently 3 or 4 weeks later, when I've got a happy knee instead of an effused knee, then inject the HA. And I think that probably there's a likelihood that we might get a better longevity of duration of action. But it also highlights at that point, that 4-week point, that if you're actually starting to get a recurrent effusion again, despite the steroid injection, that the HA is probably not the way to go at that point. But yeah.
Aru, any comments?
Nothing more to add, Sachin. All been covered.
Okay.
But
yes, Dr. Jha.
As far as effusion is concerned, unless it is very large, it should not be considered as a contraindication for putting an HA inside.
Agree completely with you.
Okay.
Okay, Aditya, thank you.
What is the cause of effusion, basically? We have to find out the cause of effusion. So you have to rule out all the markers.
We did. We ruled out the inflammatory markers were normal, and when we aspirated it, it was a yellowish. It wasn't a purulent effusion. There was no pus in the joint. And we actually sent it for a gram stain as well as culture, and it all came back negative.
ANAs and RA factors and all are normal, basically.
Oh yeah, he's absolutely perfectly fit and normal. In fact, this was given about a year and a half back, and he's still doing well.
I personally feel that he's loaded his joint, which is why he's got an effusion. He's got loss of meniscus tissue, and probably if you go into his activity levels, you'll find out that he's done some eccentric or unusual loading of his knee, which is probably why he's got a flare up, and that's probably one of the reasons why. I think even if, as you rightly mentioned, since he has got access to all sort of imaging, that's why you really can't ask for a repeat MR scan. But in these situations, doing a sensitive MR scan on a good 3T machine and possibly combining it with a cardiogram will also show if he's done some damage to his to his cartilage, which is again the cause of his effusion and pain. Yeah.
May I ask a question, sir?
Yeah. Please.
You're absolutely right. There was a history of overuse because of long COVID duties. Now, here's another question that I want to ask the eminent panelists. How many of you would actually recommend hyaluronic acid injections after ACL reconstruction? What's your thought on that, sir?
So if you ask me, what is my personal clinical practice? I do them 4 weeks to 6 weeks after doing any chondral arthroscopic surgery. So if I've done, say, osteochondral cylinder transfer, or if I've done an abrasion, or if I've performed any form of cartilage surgery, then I bring them back after about 4 to 6 weeks, and then I do a viscosupplement injection, just because I feel probably that there's good data that does suggest that doing an HA injection does improve the outcome of your chondral surgery. So that's my take on it.
I do exactly the same. I mean, if I do a microfracture, I tend to do more microfractures than warts or anything. So if I do that or I do a chondroplasty, I would usually do an injection. I do not have a time scale, but when I see the knee is quiet and the post-surgical effusion has settled, then I would do a hyaluronic acid injection. I do it for my shoulders now as well. I mean, there's evidence from Leonard Funk, him, he started using it for his rotator cuff repairs, and I've used it over the last 3 years, and I've found there is a difference in the rehabilitation. So definitely. Even post-ACL, as your question was, if I do a meniscectomy, which I don't prefer to, then I would do a hyaluronic acid injection as well.
Dr. Kapu, your question was of the simple post-ACL, or as Dr. Tapasvi mentioned, some chondral surgery?
No, I personally would, in my practice, unless there has been some amount of cartilage work, I would not give a injection of viscosupplementation. I agree with them. I just wanted to know what everybody else does.
Yeah, I agree with Dr. Tapasvi, but I would tend to give earlier than 4 to 6 weeks. So, but if there's no chondral surgery, no cartilage surgery done, pure simple ACL, I don't think the role for hyaluronic acid injection.
One of the reasons why I prefer around 4 to 6 weeks is that, this is the usual time when they're transiting from the phase 1 to a phase 2 exercise program. We're going to be initiating some form of impact activity in the same. And I do find that just gives me a chance to aspirate a bit of effusion that they may have, so their quads work better. So which is why I usually work around the 3 to 4 to 5 week time. It just gives me an opportunity to aspirate that effusion, which just makes them feel a lot more better. I mean, that's the reason why I do it at that time. Yes, Jane?
There might be a paper that helps, and I can't for the life of me recall the lead author's name, but it was written using one of the Segugaku Corporation HAs back in the day. And what they assessed was HA injections given at the time, at the end of the arthroscopy procedure, 1 week, 4 weeks, 6 weeks, or 3 months later, and looked at the patient outcomes to determine which was the best. And they said that the best results were around about 4 weeks. So those of you who've said 4 to 6 weeks probably confer with those findings. And the only other comment that I would make is that there is a very strong relationship between patients who've had ACL tears and ACL reconstructions with subsequent osteoarthritis. So whether or not there's visible articular cartilage pathology, there's definitively likely to have been chondral stress injury. And so it may be a good case to say perhaps you could consider for more there.
Perfect.
Okay, if I've bored everybody enough, or would you like me to present a third case?
Yeah, we can do a quick third case.
Okay, please just carry on to the case, please. Cut out. Yeah, please carry on. Yeah. Okay, so this is a 32-year-old overweight female. She's got a BMI of about 33. She's had knee pain for a few weeks. However, there was no clear history of injury. She had severe vitamin D deficiency, which was reported as being less than 8. She presented with the MRI done elsewhere. She came to me from another peripheral center and was reported as a posterior horn of the medial meniscal tear. Now, mind you, a lot of these machines in the peripheries are not 3 Tesla MRIs. Clinically, she had retropatellar crepitus. She had medial joint line tenderness. McMurray's was negative when I examined her, surprisingly, although she'd been reported as a medial meniscal tear. There was no instability. Can we carry on to the next slide, please? So this was her X-ray. Please carry on. And I have the long leg scanogram in the hospital, which I carried out. It didn't show any significant malalignment. Please carry on. And given the history of being reported as a medial meniscal tear, she was adamant that she wanted an arthroscopy, although my McMurray's was negative. When I went in and did the arthroscopy, there was no medial meniscal tear. However, she had severe articular cartilage changes both on the femur as well as a little bit on the tibia. Please carry on. So this is what we did. She had some amount of relief after the washout and debridement. On the femur, it was about grade 3. We gave her a shot of Visco supplementation at about 4 weeks. It's only been about a month and a half since she had the injection, and she's doing all right. But what next?
Aru, what next? What's going to be your take now?
And what was done, the arthroscopy for cartilage, Dr. Kapoor? Did you?
Because it was like a grade 3, I didn't want to go down further. Additionally, the MRI didn't show bone edema. It was reported as a medial meniscal tear, and surprisingly, there was no torn meniscus. It was actually severe cartilage changes. So I debrided the joint. I didn't do much more at that point in time and gave her an injection after 4 weeks. I'm still waiting to see what's next.
But did you use any radiofrequency ablation to smoothen the cartilage surfaces on the arthroscopy?
Yes, I do have that available. We do that routinely, yes. Whatever was the uneven joint, we debrided.
Okay. So after 4 weeks, gave an injection. How is she now? She is now...
It's just been 6 weeks since the injection, sir. She's still got a little bit of pain, but she's better. Whether that was the washout and debridement or the Visco supplementation is a little early to tell. But I'm convinced that she'll be back.
Well,
I think I put her on to bracing weight loss because she's about 33 BMI. I think weight loss will also help.
I think that's the most critical thing. We're losing weight and building quadriceps. I think there is no role of medicines here or surgery here. I think she needs to change her lifestyle, build her thigh muscles, get into a thigh building program, lose a lot of weight. Otherwise,
and she also had severe vitamin D deficiency, which is
that will help.
Yeah,
I think in India most women have severe vitamin D deficiency, and that is contributing.
So, would you consider giving this lady early PRP in addition to Visco supplementation, or would you repeat the Visco supplementation after some time? Sachin, sir?
That might depend on how long her length of duration of action is. So if she finds that the Visco supplementation lasts for a year or longer, then I would definitively repeat that in conjunction with ensuring that she changes her lifestyle and reduces her weight. And I'd also look to see that she doesn't have osteoporosis and manage that, because that will have a significant impact on her subchondral bone. But if her Visco supplement injection doesn't work, then she's failed that. She still needs all the other things, but maybe a PRP might be a second option.
So now that
low dose of Etoricoxib also for at least 2 to 3 weeks.
But ma'am, if you look at the arthroscopy picture, there is already cartilage damage. So would you not want to give PRP a little earlier, since you've seen cartilage damage anyway, or would you still stick to Visco supplementation?
I hate to be the bearer of scientific research, but there's no evidence at this point yet that PRP is regenerative to articular cartilage. So I think we probably need at this point to consider it along similar lines to the Visco supplementation. So I'm not sure that actually changing to PRP is necessarily going to be regenerative. There is a small amount of data from Zimmer Biomet's N-Stride, which is a different growth factor concentrate, to indicate a longer duration of action, and there were some changes on some patients' MRIs. But I think that's the only evidence that we have that it's actually any better than a Visco supplementation. I'm not sure that we could say that it is, but I agree with you that looking for improved growth factor technologies down the track might be partially an answer here, but it's not entirely.
I would agree. Yes, Aditya.
I think ma'am is perfectly. I think that's very, very true. In this country, certainly PRP is being used as a panacea for all sorts of. Sorry to set the cat amongst the pigeons, but it seems to be marketed as the answer to all sorts of problems.
It's not just this country; it's the whole world. So I think no country is immune right now. Huh? Yeah.
So, Sachin, like to ask, what's Dr. Jain's experience of using ACS, autologous condition serum?
So there's 2 autologous condition serums. So I just want to clarify which one you mean. So the Arthrex make a kit that is called autologous condition serum, and it's platelet poor. It's PPP, so that is one. And then the other one is an autologous conditions protein solution, which is the Zimmer Biomet one, which we would otherwise call N-Stride. So I've actually used that quite substantively. We did the HIP trial with them. So I do find that it actually works a little bit has a longer duration of action than leukocyte-rich PRP as a standard formula, and that's what's been borne out by the clinical trials, but there's not yet any evidence that it's regenerative.
Okay. I'll stop. Can we stop there? I think the others have to present their cases also, so I'll stop there.
Sure. Thank you so much, Aditya.
Thank you, sir.
Great cases, great discussion. I think really very nice to a lot of good data and a lot of good thought process that's coming through all these cases. We'll move to the last case presentation for today, and it's a great pleasure to invite Professor Jha. Professor Jha is going to come to us from Patna, and he's going to be presenting his case. Over to you, sir.
Right. Thank you.
Thank you.
Just a moment. Is my screen visible?
Absolutely perfect.
All right. So, friends, I have only one case to show. This is a lady who entered my chamber in this flexed position of the left knee. This was 17th February this year only. She is 54 years. And her left knee had acute agonizing pain since last 5 days. Mild pain was there for 4 to 5 months. There was limp, and she was limping on a flexed left knee. History of intermittent locking surprisingly was there during the previous 3 months. Now, on talking to her, she said that the right knee 2 years earlier while she was negotiating a step down from kitchen to courtyard, felt like as if a glass had broken inside with crackling sound within, but presently had only mild pain in the right knee. History of pain in the back radiating in the lower limbs was there, which were persisting for 7 years, and 7 years earlier it was there and is persisting since 5 years. But presently the back pain is also very mild. On the same day on examination, the left knee was found to be 40-degree flexed. There was swelling and fluctuation was there. Knee was manipulated gently and it could be straightened without any sound inside. Aspiration and intra-articular durolin was given after properly investigating the patient. The limb was temporarily immobilized in a knee brace and the patient was put on teriparatide and tofacitinib. Same day, the X-ray available showed mildly reduced medial joint space. MRI showed grade 2 signal in medial meniscus, body and posterior horn, and there were few osteochondral loose bodies. DEXA scan was also performed and the spine T-score was -3.4, left side neck femur was -2.7, and right side neck was -2.2. Naturally, there was quadriceps wasting. This is the X-ray on the same date. These are the X-ray of the sacroiliac joints along with the lumbar spine and also the lateral spine. Now, the X-ray reports are visible, which does not write anything very different than what is observed. This is the MRI, and the MRI says grade 2 signal seen in the body and horns of the medial meniscus, moderate joint effusion with associated synovitis, and synovial thickening with few osteochondral loose bodies. Now, these are the various T-scores as I have already described. Anti-CCP was done, it was normal, and rheumatoid factor was negative, uric acid was within normal limits, kidney, SGPT, etc. were normal. ESR was only 10. Vitamin D was at the lowest level, 34. Now, this patient was sent back to home after aspiration and intra-articular durolin injection. When the patient came after 2 months, she had marked relief in pain in the knee and in the back also. The intermittent locking which she had was not there since 1 month. After going from here, she had it once or twice, but not at that particular moment in April. And she was allowed to continue on teriparatide and tofacitinib. Then she comes 3 months later on 23rd July, and the patient came comfortably walking with restoration of movements except terminal flexion, and she was continuing on teriparatide and tofacitinib was replaced with sulfasalazine. Now, this is her straight leg raise in July. This is how she can flex it. This is how, I think this video will not work. Otherwise, she can walk very comfortably. Now, going into the discussion part. Friends, we have been discussing about intra-articular injection of steroids of HA. But there are other intra-articular injections mentioned in literature, and they are sprifermin, which is fibroblast growth factor, even Botox, which we have been using in our spastic patient, and also is being used by beauticians for facials. So intra-articular injection is said to have been giving encouraging results, and capsaicin, which is usually used as topical gel, even intra-articular injections have been given. Low molecular weight human serum albumin by the name Ampion has also been given, and tenezumab 3, which is nerve growth factor, has also been used. As far as nerve growth factor is concerned, it is sometimes observed that an intra-articular injection of nerve growth factor may deteriorate, rather improve the osteoarthritis features. Well, friends, out of all these, even biologics, they have been used intra-articularly, but none of the sequences in which they have been used have shown very promising results. So, two things are have very prominently found their place in treatment of osteoarthritis, apart from HA, and they are intra-articular SM04690, which goes by the name of Loresivivint. This is available in the market as Adavivint, not available in India still. This causes cartilage regeneration. This protects from cartilage catabolism, and there are claims of significant difference in joint space width. Now, talking of joint space width, Dr. Tapasvi has rightly mentioned that cartogram is an investigation which should be done. And if there is 1% decrease in tibial articular cartilage, there are 20% and more chances of that patient going for joint replacement within 4 years. So cartogram has a significance in investigation as well. Phase 3 trial, Samumed, same Loresivivint, is given in various doses, and it is used also intra-articular. So, many of us are conscious of the use of this particular drug, which goes by the name of Gilreta, which is nothing but repurposing the older drug, triamcinolone acetonide. Now, they work through PLGA microspheres, hence maintain concentration in joint for several months after a single dose. There are claims that it provides pain relief for 5 to 10 weeks. Friends, since we are into a discussion into various intra-articular injection modalities, we should also know that intra-articular gene therapy has come in vogue, and the first arthritis gene therapy goes by the name of Invosa, which has been produced by South Korean Ministry of Food and Drug Safety. Now, gene therapy is intra-articular recombinant A adeno A virus. This transduces synovial lining cells as well as chondrocytes throughout thickness of articular cartilage. Considerable advantage in osteoarthritis, in which chondrocyte dysfunction has a key role. Invosa is 5th gene therapy approved product for anywhere in the world and 2nd for a non-lethal disease. Friends, during our discussion, we have been talking about what during the interval period between 2 injections should be prescribed. I have a hypothesis to say because of my interest in rheumatology. Well, sulfasalazine and tofacitinib are the 2 drugs. So they effect on the protein profile of articular chondrocytes. They open up a new vista in the management of osteoarthritis. They have novel functional aspect of tofacitinib in osteoarthritis. So this tofacitinib, a small molecule, this claims to promote cartilage extracellular matrix generation. So extracellular matrix, that is ECM generation, takes place, thereby inhibiting the osteoarthritis development. So intra-articular small molecule goes by the name of BNTA, and this is effective. What it does, it increases the cellular level of adenosine, known to have anti-inflammatory activity through the down-regulation of AMPD2. Now, sulfasalazine has mode of action, inhibits tumor necrosis factor alpha expression. It may reduce secretion of inflammatory cytokines such as interleukin 8 and may also suppress B cell function. Without going into much detail, I will say sulfasalazine has antibacterial effect, anti-inflammatory effect, and also has immunomodulatory effect. In the end, I would like to say, and I always say that osteoarthritis and rheumatoid arthritis, there is an element of parallelism in their pathology. So in one of the editorial in Future Drug Discovery in 2019, Charles Melmood said, however, I believe at this time that one thing is certain regarding management of osteoarthritis. It was previously proposed that since many of the cellular events characteristic of rheumatoid arthritis overlap at some time with those in osteoarthritis patient, why not use those accumulated successes in the drug therapy of rheumatoid arthritis to treat osteoarthritis? Thank you, friends. I might have overstepped in my discussion. I may be excused for that. Thank you.
Thank you so much, sir. I think this was a big eye-opener for all of us, because the kind of data that you've presented along with the kind of research, I think absolutely I was not privy to that kind of information. So thank you so much for sharing all of these newer concepts and a different insight for looking at the way we should be looking at osteoarthritis and the novel drug therapies that are there to come in the near future. So any questions for Dr. Jha on his presentation, on his case? If anyone has any comments to make. Yes, Aru, any comments, any questions?
No comments. As I said, is an excellent overview of future direction on the treatment of ONE. I'd like to thank Dr. Jha for that.
Excellent. So,
is anybody else using DMARDs like tofacitinib for osteoarthritis?
Not me, for sure.
I have a little concern about tofacitinib. I don't think it's a very benign medicine.
It is definitely not a benign medicine. You have to look into various parameters before prescribing it, and especially you have to see that it is not prescribed for a very, very long time. So any patient, especially who has got any history of infection, you should not prescribe it. It can cause cardiac events, it can cause respiratory events, and maybe you might vaccinate your patients against possible secondary infections like pneumonia, herpes zoster. But then dose becomes very important. Very recently, I was attending European League Against Rheumatism, which goes by the name of EULAR, and there was a presentation that has tofacitinib stood the test of time, and it was said that it is in the higher doses that complications do take place, and the higher doses in which it is recommended is not only 5 milligram BD, it is even 10 milligram BD. And I will say, if the patient is more than 65 years, don't use more than 5 milligram once only. So restricting your dose, and especially for Asian patients, I say it should be only half the European dose, because body weight of our patients is not that much.
Excellent, thank you. So I think any last comments from Dr. Jain before we wrap up this session?
I tempted just to make a comment relative to these things, because I think whilst it's exciting, it's probably not really, it's a little bit like the frontiers of growth factor technologies. We haven't got the answer. Because at the moment, the molecular characteristics of osteoarthritis do show a difference between patients who classically have osteoarthritis and those who have rheumatoid. So they're not the same growth factor profiles. That's actually kind of important to remember. It's also important to remember if we're using PRP in that setting, because what growth factors you choose will kind of be determined by what you get. It probably is also emphasised by the fact that hyaluronic acids have been shown not to work effectively in rheumatoid arthritis, which adds a little bit more to that argument, and that TNF-alpha blockers have not really been shown to be as effective in osteoarthritis. So whilst I agree that it might be there in the future, my reservation is that I don't think that any of the agents that are currently being studied have actually got that great clinical evidence yet. I'd love to see that they do. It would be a fun area to work in. But I think really, as Dr. Rathora suggested, that the side effect profile is often higher than what we would like to see in a patient with non-demonstrable inflammatory arthropathy. So for me, I think probably if I look at the sort of safety profile, that I would stick still with the hyaluronic acids. If I look at my wish list, then these components are definitely on it, alongside of a whole stack of other things, and it's an exciting space for all of us to work in. And thanks to everybody. It's been a wonderful discussion.
Thank you. Any last comments on Jane on coming back to the same particular aspect, is that what would be the take-home message if you're looking at biosimilars? And I think because that's probably the most important take-home point. Do all HAs behave the same? So one last comment on that as well, please.
No, there's definitive evidence right throughout the literature that indicates that high molecular weight HAs, particularly those, I'm losing my AirPods here. So with the Nasher technology as the highest of those, that they work better in all settings in terms of anti-inflammatory behaviour, pain relief, and chondroprotective effects. So I think we probably need to all understand that there's a differential between different HAs, and make sure that we don't treat the class as one.
Agree completely. So I think, to safely conclude today's meeting, probably I would come back to the same aspect where we started from, is that there's a large treatment gap, especially in probably 90% of patients with knee pain. Osteoarthritis still remains one of the major causes of knee pain, at least in our country and of course globally as well. You've presented excellent data to suggest the same. Effective use of HA in the correct indication for the correct patient is emerging to be the front runner to treat patient pain effectively and improve their quality of life. Fourth important aspect or take home point is that HA has been shown also to be a very useful adjunct when you're doing any form of cartilage surgery. Fifth take home point would be that not all biosimilars are similar, which is really very important. I mean, though they may all look as oranges and apples, but still within the same, you have different qualities of oranges and apples, some that don't taste so good and some that really taste very nice. So it's really important that when you're choosing, you have to pick your winner. You have to you have to pick something that's going to take you a very long way ahead, because once you're able to give that kind of gratifying result in your patient, he's going to be happy. He's going to come back to you again, and he's probably going to bring his friends and his family as well. So I think it's important to understand that, it's not just the product or just the label, but it's what goes inside it, which is equally very important, which helps get a good adjunct. And I think the last point which everyone did suggest is that this is one spoke in the whole wheel of treatment of knee OA, and of course we have other modalities which are really very important, including various drug therapy, weight management, weight loss therapy, which was which Dr. Gaurav did insist quite a lot on. Dr. Armugam and Dr. Aditya also spoke on various exercise regimes, as well as looking at complementary therapy. Dr. Amit also suggested how do we institute certain imaging modalities, how do we approach them. Dr. Jha came in with his wonderful experience on all the newer emerging novel drug therapies, which probably would occupy a significant space. So if we meet again on the same platform, maybe in 3 years, 4 years, 5 years, we could be discussing newer things. And as Jane did mention, is that newer drug forms to treat holistically this whole aspect of knee pain are really emerging very fast, and we need to watch out this space. So my sincere thanks to the entire Dr. Reddy's team for putting together this fantastic program, for selecting an excellent topic, for putting together such fantastic faculty. Jane, you're an excellent speaker, vast amount of knowledge. I think I would probably spend a couple of weeks trying to gather that data that we just presented, which was really concentrated in 15 minutes. I can see that you've put in 3 decades of your life minimum trying to generate that much amount of science for us. So, thank you on behalf of all the listeners today. Thank you to my friends, Dr. Arumugam, Dr. Jha, Dr. Amit, Dr. Gaurav, and Dr. Aditya for taking time off on Sunday afternoon. They could have done something better than sit in front of a computer screen, but they're all very kind to be with us. And of course, they were here because of a very important reason, that academics and science takes precedence over everything else. And ultimately, this is what helps us be a good care deliverer or a caregiver in the society, which is what we're here for. So thank you so much, and I hand it over to Team Dr. Reddy's for the concluding remarks and their impressions of the last, 122 minutes that we've spent discussing various aspects about HA.
Yeah. Thank you, Dr. Sachin Tapasvi, for summarizing the entire discussion into a snapshot for every listener out there. And personally, I've learned a lot, and I'm sure the qualified clinicians have already picked up the practice enhancing messages which came across in this meeting. I'd like to thank Dr. Jain. Amount of work, which has been put into a capsule size presentation. I'm sure it can be useful for all the practitioners out there. I'd like to thank Dr. Gaurav Rathore sir and Dr. Armugam sir for making their comments on the case presentations which happened today. And personally like to thank Dr. Jha, Dr. Kapila, Dr. Aditya Kapoor sir for bringing out that discussion which is relevant to the Indian practitioners. Thank you very much. And
some words from Vijay. Vijay, some last comments from you, being the head of all divisions. Yes.
Thanks a lot, Dr. Tapasvi. I think for me it was a very, very enriching experience. I think to have been part of this elite group, listening into the experience that came through these discussions, I'm sure would be extremely important for the clinicians who also listened into all the experiences that were shared. Would only help them, as you had rightly mentioned, to deliver better treatment outcomes for the patient. And of course, a Sunday afternoon well spent for all of us. I'm sure we could have all chosen to do other things, but I guess in the interest of science, in the interest of our patients, I think I would like to believe that it was time well spent. The last 120 minutes, 123 minutes well spent. Thanks again. Thank you so much for wonderfully moderating it, Dr. Tapasvi, and thanks a lot, Dr. Jain, for encapsulating the experience that you shared. PhD work in PRP you did mention. I'm sure there would be conversations that we would be having to try and understand that topic a bit better. And thanks to all the case studies that were presented. And thanks a lot, Dr. Armugam and Dr. Rathore, for being part of the support that you extended as being the panelist. Thanks a lot. Thank you so much again.
Yeah, don't forget to share the link to her injection technique video when it comes out.
Absolutely. Absolutely.
This is now in public domain that everybody is looking forward to your video technique link, which is supposed to be published soon, right? Looking forward to it.
Sure.
All right.
Bye-bye.
Great. Bye. Cheers.
Thank you. Thank you.
Bye-bye.
Hello.